let's
Yes.
start the discussion.
Okay, so let's start with our panel discussion today. So my first question is to all the panelists. What, sir, according to you, is meaning of bad news? What is the spectrum? So I want to know from all the panelists what, according to you, means bad news in medical practice. Starting with Dr. Bowman.
First, I'll tell you, as far as possible, we don't want to use the word bad news. We'll tell it serious news as far as possible, because bad news doesn't look very good to be told to the patient. We say it's a serious news. Secondly, bad news is very difficult to define, but it's a news which will change the lifestyle of the person whom you are telling, emotionally, physically, and all these ways by which his thought process becomes very poor, at least for that time. So this is a news which shakes a person. That is what I call as a serious news. It can be, as Dr. Ravi said, at the time of diagnosis, in oncology, at the time of relapse, or of course, when the time we are about to lose the patient, or when we call it as a palliative care only. So this is something like what we call as changing the whole thing of the patient or his attendant.
Dr. Tang, please.
So I think that's a good perspective that, instead of calling it and saying that I've got bad news for you, you couch it in some terms by which you make the blow a little softer. But, I would just like to expand the scope of what this news might constitute. I mean, a lot depends on the basic resilience of the person to whom you're talking. So something might be quite routine, or it might even seem trivial to us as medical practitioners, but it may be taken very seriously or in a very negative light by the one who's receiving it. So, for example, let's say a woman is in labor and she's not progressing, and I have to do a C-section for her. So even that is something which deviates from what they expected. So I agree with what Sir has said, but just to expand the scope of our discussion, I would say that news which changes the course of events significantly, I would say that that is news which has to be delivered in a sensitive and a sensible manner. And I think our focus should be along those lines.
Yes. Dr. Sangvi, sir, your views on.
You are muted.
Sir, you are muted, sir. Can you unmute yourself?
Sorry.
Yeah.
So, like I said, I'm a man of few words, and I have a very simple definition of bad news. It's basically unpleasant news or news which people don't want to hear. Especially in our situation, when we talk about bad news, it is not necessarily bad news, but they are unpleasant news. I mean, you talk about the seriousness of a patient, and they always want to hear only good things. And you have to manipulate your language, do circumlocution. No, this patient is not doing well. So you find ways to pass on this message to the relatives in a pleasant way. I think that's what I want.
So do you think that there is a spectrum? Or it's just that it is something out of unexpected, something that is not expected? Would you grade it?
Sorry, I can't hear you.
Is there a spectrum? Would you grade the bad news? Deal with it accordingly.
Sorry?
Would you grade the bad news? Is there any spectrum?
So, I mean, when it is really bad news for us to pass on to the patient, it is that the patient is serious or he's having a serious diagnosis. And now, this serious diagnosis would either have a high morbidity or a high mortality. both of things are bad. Once if the patient are reassured that okay, we have a sick or a serious patient, but this child patient is, I always keep on referring to child, or because I deal only with them. So if we can convince them or pass a message that yes, this child is serious, but will come out of it, then it is what we would say, what talk about great. But once we know that things are going to be bad, like if I have a preterm who's had intraventricular hemorrhage grade 4, and I don't have any good news to offer, and I don't have any positive thing to say about this child. So these are two different things depending on the morbidity and whether even if the child survives, is this child going to be normal? That's the next question. So, like in a case of birth asphyxia, I mean, if it's a grade 3 Sarnat stage, that is a badly severe birth asphyxia, then we know almost 100% of them, even if they survive, are going to have major neurological abnormalities. So, we have to pass on this news, like I said, depending on the morbidity and the chances of mortality.
Absolutely. Thank you so much.
So coming to the next point of discussion, this is for
If
Did you have to add anything, Dr. Parikshit?
Yeah, so as
Sorry.
you were asking that, is there a spectrum? I think there is a spectrum across patients, their conditions, and there is a spectrum across specialties also. So, what may be fairly routine for a particular specialty may be exceptional for another one. So I think that also has to be considered.
So point well taken, Dr. Parikshit. And that's how I'm moving out to the next question, to a specialist who has been practicing oncology, where you have a lot of serious patients. And as many times he must have broken a serious news, which is a bad news or a serious news for the patient's relatives. May it be a young patient, a child of a parent. So, Sir Dr. Bowman, in your more than 3 decades of practice, how your approach towards breaking bad news, I would correct myself to serious news now, has evolved, and what factors have impacted the gravity of this serious news? And if you have any some examples or stories like these or cases where you have faced challenges in this, can you share those with us?
I started when I just left Tata Memorial Hospital. I met few of my seniors saying that I'll be going into practice. So one of the very, very senior pathologists, whom most of the India knows, she told me that, Bowman, don't, uh, whenever, don't make everybody happy. You are not here to sell medicine. That was the thing that was told to me by her. And as soon as I joined practice, so this was the thing, that we are not here to sell ourselves. This is what we have to be very truthful to our patient. That is the thing which we always have in my mind when I started the practice. Few of the surgical oncologists who were referring to me, they then told me, Mohammed, तेरा तो बात ऐसा करता है तो सूरत इतना bad news देता है, and they stopped referring patients to me. So then slowly I realized, slowly over a period of time, I realized that it's not that only serious thing and the bad thing that the patient should be told. Let us start off with something good and then go to bad. So that is what it evolved slowly over a period of time. That it is not that we should be, yeah, it is true that we should be truthful to our patient. We are not selling ourselves by telling them good news, all those things. But at the same time, it should be a mix of both the things. And that is how it started. And now we are so much used to telling the same thing again and again and again, because we see very limited number of diagnoses like breast.
So according to you, what factors would affect, when you actually tell the bad news? Like if there is an unexpected outcome or an expected outcome, like somebody who has had come for fever and suddenly arrest in 24 hours or something like that, or somebody who has a cancer for a long period and then succumbs to the illness. Is there any difference? Does that change in acceptance of the relatives for this bad news?
In oncology, when they come to us, most of them know that there is a malignancy, and most of them have the concept that malignancy means not so good, and so most of them are little bit prepared. But anything unexpectedly happens, I do agree it's a big shock to us also, because most of the time in oncology, we know that this patient is now going to go downhill. They have multiple series of treatment with us, and if they are not responding or something, the patient and the relatives also try to know this fact. But yes, when it happens suddenly or unexpectedly, which happens very occasionally now, with as you go on seeing so many number of patients and everything. But yes, when anything unexpectedly happens, you must tell them the truth and the fact that how it has happened and what has gone wrong. That is what
So,
that you should tell them.
so how
Sir,
do you manage?
is there
Suppose there is a
any network issue at your end, sir? Bowman, sir?
No, no, no,
Some disturbance?
yeah,
no.
the
I can
voice
listen.
is breaking in between.
Yeah,
My
voice is breaking.
my voice is breaking.
Yeah,
Yeah,
your
yeah.
voice is breaking.
आगे देना ना मुझे वापस वो earbuds.
Okay.
So how do you handle this situation, sir? Like for example, you have a 14-year-old child
Oh.
who comes with fever of unknown origin and gets diagnosed with some blood cancer like ALL or something like that. So, and then you have to break this news to the parents. And it is just like that he has come with an unknown etiology of fever, and suddenly it is found that okay, this is something which is very serious.
If they have approached an oncologist or hemato-oncologist, most of them know that there is something wrong to them. So it is just a smooth process by which we should say, like if I have to tell them, any serious news or what we say as a bad news, we do tell them, but at the same time, it should be always with a hope that see, it is ALL, yes, but there is treatment for ALL. There it is like this young lady has got a breast malignancy, but there is so much of treatment now. Science has evolved so much. Like you can tell them, of course, whenever you say any serious or bad news, it should never be. Most of them, it should be in a silent atmosphere where patients and the attendants are there, and you should have also some time as a physician or an oncologist or pediatrician or anybody should have some more time to be sitting with them and telling them. And generally, it should not be with major jargons, medical jargons. It should be straightforward. And I tell them straightforward, see, there is a disease, but there is a lot of treatment options available also. So at the time of diagnosis, obviously, ALL is potentially curable. Breast cancer, now so much treatment options are available. So many malignancies, things have evolved so much. So we should give them that hope also that there is something that we can do for them.
So it is important to give some hope to wherever you have an unexpected event or something. Right?
Yeah, unless it's a mortality which has occurred, then obviously.
Yeah, obviously that.
So you might be getting many doctor patients coming with diagnosis of cancer. Now we want to know how do you manage to, break the news to a doctor colleague who has got cancer.
Most of the doctors are well read, as you know, and most of the doctors who come to me know that they have something inside them. So it is, but only thing what many of them may not know that they have a very advanced stage. And this is the news which I have to tell them. It does affect us also to tell our own colleagues the same thing. And at the same time, we also think that what would you have done if you had that? So we try to tell them that this is of course a fourth stage disease or a bad thing. But there are a lot of treatment options available. That is what we always try to cover up with them. That. But as doctors, most of them know that what is the scene behind. So it is not really very, very difficult for us to explain to a doctor who knows most of the things.
Many a times it so happens that Indian families mostly want to shield the adult patient from knowing the truth.
Very true.
How to handle that? How do you handle that? Do
Very
you
true.
break the bad news to the patients directly
I will.
or avoid it as per the relatives' wishes? Or sometimes, you have to tell it to the patient.
Yeah, I will tell you. This is a very, very important thing which happens in our culture. That I have worked in Seattle, I have worked in Middle East also, and I'm here again. So everywhere else, the patient has to know what you are telling to the attendants. But here, as you have rightly said, our culture doesn't allow, and most of them. But there was a small study which I went through, and where 70% of our patients in India also want to know the diagnosis, but it is the attendant or the close relatives, they don't allow the patient to be there. If you ask the patient, you want to know, he will say, yes, I want to know. I'll just give you an example. I had a young lady who had a Hodgkin disease from Middle East, and the parents never told the girl, the lady, that she has a Hodgkin disease which is treatable. So every time when I used to go for chemotherapy, she will say, she was in admitted in Just Look, she'll say, I'll jump out of the window. Arre Baba, I would say, catch her, please. Not to do, and all those things. Then one fine day, I lost my head and I told the attendant, the relative, please go out. Let me talk to her. I told her, see, you have a disease like this. You are a sensible lady. This is a potentially curable disease and you'll be absolutely fine. She said, my parents didn't tell me. And next, all the cycles went on so smoothly that there was absolutely no problem. She would come smiling, she would take the chemo and she would go away. So it is very important for the curiosity kills the cat. So if you don't tell them, you are doing injustice to them. So I try to convince the relatives, the attendants, that please don't do that. Tell them. Allow us to tell them. Maybe we may not tell them very seriously, little diluted, but we should tell them.
So it is better that the doctors tell the patient than the relatives telling the patient.
Absolutely.
That is what the take-home message is, right?
Absolutely.
Can I add to what Bowman said?
Yeah,
so
please.
This happens in our practice also when there is a preterm neonatal mortality and all the be all and end all relatives, they know everything and how to handle the mother. And they say, nahi, usko nahi batana, usko nahi andar jaane dena, mat dikhana. And every time I ask the mother, do you want to hold your baby in your arms, in your lap? And none of the mother have refused. And in fact, it is a big relief for them that they've held the baby in their arms. So we have to sometimes counter such relatives and tell them, look, it's not that you have to take the decision. She's the mother. She's given birth to the child. It is her right to hold or treat the baby the way she wants.
Absolutely.
I can second that opinion completely, because even when, occasionally we have a stillbirth, the same holds true. The woman's relatives will say that you shifted the baby to the NICU and after a few days we'll break it to her, etc., etc. But I don't think women can be convinced in that manner, and it's much better to be upfront right from the get-go.
So Bowman sir, you have been managing serious patients, and most of the time, they are sick patients with terminal cancers also. And it must be disturbing for you also emotionally. Sometimes, you lose a patient who is being doing well, or, who is being treated for many months together or years together with you, and then suddenly you lose the patient, or over a period of time you lose. So how do you manage yourself to protect from emotional burnout? Or does it happen, or how do you manage?
In the beginning phase of your life, it does happen a lot. It happens a lot that when I was in Tata Memorial Hospital, and I used to see young patients dying of acute leukemia, sudden deaths, all those things would produce a lot of problem mentally to us also. But, you should not say, but slowly, little bit of sensitization also occurs. And with sensitization, it is like that you are treating the patient. You are the doctor of the patient. If you start, I had one colleague who was with me in TMH with me, and he was also very much nothing personally, but like that acute leukemia, young lady was there. And when she became bad, he also started crying. So I had to tell him, please go out, I'll take care of her now. When she was gasping and she was very bad. So it is like that if you are tough, you can take care of them. So in the beginning, you do feel very sad and this, but I think so over a period of time, little bit of sensitization comes and you are up to it. And you have to be up to it to take on the challenge for the next patient.
Sir, what has brought about this change? Is it the professional maturity, or it's just that you see that day in and day out, so you kind of get desensitized, or because oncology is evolving so much that now you have many more options available. So what has made
Or it is just the
So,
gray hair which touches us.
so this is again another important, very important thing in oncology. When you are breaking the serious news and you are telling the patient, you yourself should be updated, because there are so many treatment options which have come up now. You know, immunotherapy, there are targeted therapies, and there are so many new things which come up and up. Although we know many times that the patient may not be able to afford, but it is our duty to tell them. So many times in this also the discussion goes on and on and on for one patient. So
yes,
and
yes.
and with maturity also, as you rightly said, with professional maturity, you start understanding the opposite person also, and it goes on.
Because I remember a patient of mine who had managed for 15 years. She had CA breast, she had CA uterus with metastasis and all those things. At every point, went on giving her new hope and new treatment option. And this lady had survived for 15 years. Now she is no more, but her husband still remembers. You remember that case.
Thank you. And if you allow me, shall I leave? Because there are some bad patients still waiting.
Thank you so much for.
Thank you so much, sir, for sparing time for us.
I know Bowman for I don't know how many, more than 25 years. And the first time I've seen him speaking so much.
That's why we are privileged to have him, and we are so thankful to Dr. Bowman for sparing the time. And
Right. Hello.
thank you so much, sir.
We should
Hello.
pat
Thank you.
ourselves that achievement of UMANG to get him here and make him for half an hour.
Hello.
Yeah, it's a noble cause that we want to follow. And thank you, sir.
Thank you. Thank you very much.
Bye.
So now my next question is to Dr. Sangvi and Dr. Tang both. So when you have to break the bad news, how do you do it? Like how do you take out a separate time, a separate place, speaking in privacy, and how do you decide that how much information to give it to the patient? Do you prefer to give it in one go, or you break it up in different sessions and then give the information? And how do you check whether patient has understood exactly what you want to convey? How do you go about it? So Dr. Sangvi first, and then Dr. Tang can answer.
So for me, when I see a preterm, I have a preterm newborn, like 24, 25, 26 weeks. So the beginning is always with respiratory support. The child is on the ventilator. And sometimes I have to break the happiness of the parents. When they ask me, how's the baby serious, the baby critical. So first of all, I look for a secluded place wherever is available. We work in corporate hospitals, and the old house. I work in the relatively older hospitals where they don't have such places or corners. So I take them to a corner. Then I ask them that all the decision-making people should be here, because what happens is the father is the least important. There is a grandfather, there is a tauji, there is a chachaji, there is a mamaji, who are the decision makers of their family. Then I switch off I put my mobile in the silent mode, and I request everyone to keep it in silent mode. Look to a corner, and then I start talking to them. I talk to them what is prematurity, how long a baby stays inside the womb, and when it's come out early, I explain to them what prematurity actually is. And I go by first trimester, second trimester, third trimester. So this child has come out in the second trimester. And I tell the child is formed but does not have any immunity, or does not have the capacity to fight disease. So in simple words, I say that ये पांडव और कौरवों की लड़ाई में कुरुक्षेत्र बच्चा है. So we are trying to see the field. And then I talk about there can be, at the moment the child is on the ventilator. So to live, remain alive, we need two things. One is heartbeat, and the other is respiration. And one of them is compromised. That means the child is serious. But I say, when I check,
I think sir's connection went off.
Sir, I will add. Maybe Dr. Tank, you can answer.
No, I think he's back. He's back.
He's back.
He's
Okay.
back, yeah.
Okay.
Sir,
He
you have
needs
to
to
unmute.
unmute.
You have to unmute yourself.
So then first defining prematurity, and then I said there are many, there's a log, Delhi bahut dur hai. And it's going to be about 2 months before I can give you your baby. In the journey, there may be problems come. As long as there are no problems, I'll tell you, baby is stable. Don't expect overnight improvement. It takes time. It takes weeks for the child to improve. And I give them a broad outline of how we are going to do what, including what we're going to do as treatment wise, what we're going to do, prevent damage to the brain, all these things. If possible, I ask one of my residents to record what I'm talking. And in one of the hospitals I work, there is a video recording also. So that means this is to play safe, especially for medical legal thing. Then I speak to them in a very layman's language. I have to use technical terms. I draw illustration and explain to them what is the trachea and what are the lungs or whatever. I do it so that they understand. Suppose the child has a congenital heart, then I have draw a diagram of a heart and explain to them where the disease is. Then I tell them that I'll be coming whenever I'm required, but I'll take rounds twice a day. If required, I'll come in between, whether it is day or night. What happens is that they have been with the obstetrician for the 6, 7, 8 months, and suddenly they are confronted by a doctor whom they don't know, but who's not talking very positively about the baby, or at the best is trying to be little cautious. So I have to get their trust. When I explain to them everything what prematurity is, they start believing, and then they fall in place. And then I say, like, I show my hands like this, like a, you see it? So this is the support we are giving. This is what the baby is doing. So slowly, as the baby starts doing on his own, we'll come down like this and allow the baby to breathe independently. Then they ask for time. How much time? So this is one thing I say I can never predict. Whether it takes 3 days or 30 days, I cannot predict. It all depends on the baby. As the baby demands support from us, we'll go on giving it. Once the baby tells us that, no, I'm good enough to take my own support and my own respiration, we start releasing it. I also inform them that I'm in constant communication with my residents and my staff. So they expect the doctor to stay with the child throughout the day and night. So I said that is not possible, and that is why we have residents and nursing staff. This is like you have an adult ICU, we have a neonatal ICU. The same thing what is done in an adult ICU is done in the neonatal ICU. And I also tell them that I am in total knowledge of what is happening to the baby. And I also say that मेरी इजाजत के बगैर परिंदा भी पर नहीं मारता. So they feel rest assured. And then, Doctor Sahab, आपका mobile number दीजिए. I said, no, mobile number I'll give you when I'm discharging the patient. Because most of the time what happens is, Doctor Sahab, मैं यहाँ खड़ा हूँ, आप कितने बजे आएंगे? तो ऐसे suppose 11 o'clock. 11:15 हो गए, आप अभी तक आए नहीं हैं. So that is what I don't. I said, I'll give you the mobile. And I give them a time that this is my visiting hours. If I'm held up, I inform the nursing staff that I'll be late, so inform the relatives. Secondly, giving the mobile number to these people is, then there are, like I said, there are mamas, kakas, taus who like to, Doctor Sahab, क्या position है बच्चे की? तो डॉक्टर साहब दूसरे बच्चे को देख रहे तुम्हारे पोजीशन बताएंगे. I said, look, when I go for rounds, then I'll come to know what is the position of the baby, and I don't discuss. This is medical ethics. I don't discuss the condition of any patient on the phone. So then they take a back seat, and then they know, once they get used to it, that this fellow comes on time, relatively on time, and talks to them every day. I make it a point to talk to them. Most important is that we have to empathize with them. Instead of just showing sympathy, we have to empathize with them, and they should feel that, yeah, we are also a part of helping them and bringing out the baby. So that attitude has to be there, and slowly as we build up a relation with them, they start trusting you. and the things move on, and ultimately they are very happy. So I generally have not had problems with these parents, because my job is still generally they do believe what I say, and you have to be brutally honest with them. You should not hide, and as long as you are doing evidence-based medicine, there is no way they will doubt your thing, because nowadays people are very smart. If you say surfactant, they know what is surfactant. You talk about non-invasive ventilation, they know what is non-invasive. They all well read.
Or they would find it.
When you utter the name of the disease, next morning will come with questions for the disease.
Yeah, they would have found it from Google by that time.
If I have a transfer from another place, there's one thing I'm very careful about is I will not speak any bad or anything about my colleague. They'll ask, उन्होंने ऐसा क्यों किया? I said, I was not there in that position at that time, so I cannot make a judgment. But for your knowledge, he's equally qualified. He's as qualified as I am. So that sets them right. I mean, they look for scapegoats. Sometimes they ask if the obstetrician made a mistake in delivering the baby, or cesarean pehle karna tha, ya anything of these things. And I said, nothing doing. And most of the times, what I try to do is, because they know the obstetrician for the last few months, the first time when I talk to them, I have, especially in a case of asphyxia, now 30% of it comes unannounced, no one's fault. Even if we are prepared, there is fetal distress, what can an obstetrician do? And so I talk to them with her standing next to me. So they also know that she is aware of what I'm talking, and she's I'm a part of her team. So by and large, then they settle down.
Absolutely correct. So you have narrated the challenges in pediatrics so well. Yes. So my question
Neonatology.
So how would my question to Dr. Tank is that what are the challenges in obstetric patients? Because in obstetric patients, the outcome is expected to be always positive. Whether it is a delivery or cesarean section or whatever it is, the patients are supposed to be healthy, and if something goes wrong, how do you break it? How do you break the ice and tell them the bad news or the unpleasant news?
Exactly. I mean, see, pregnancy and childbirth are physiological conditions, and this is something which has been drilled into us since the days when we started medical school. But the deviation from physiology to pathology is very small, and things can go wrong once in a while. So it depends on the degree to which things have gone wrong. I mean, on one end of the spectrum, you might have something like, a woman who unexpectedly needs a cesarean, but everything turns out okay. Whereas on the other extreme, it might be a perinatal death, it might be a stillbirth, or even worse, it may be a maternal death. So, I mean, it's a very huge spectrum that we are talking about when we are talking about obstetric situations. Now, how to deal with it? I think Dr. Sanghvi sir has already laid down certain ground rules that, have honesty, transparency, and follow standard practices. Don't joust your colleagues, and see that you can dedicate some time when you're doing it. So it's not something that you want to do on the fly. I mean, if you're breaking very, very serious news, you have to be 100% there with that family at that time. Nothing should take away your attention at that moment of time. And I think what really matters is the assurance that you're going to continue to look after this situation as it evolves. I think those are the things which really help in these tough situations.
Dr. Tank, you practice in a nursing home scenario. So things are a little different. In institute, we have a lot of supports when we have to break the bad news, or sometimes the relatives get violent or they start blaming the staff members. We have a lot of support system. But how to be managed when you are in a isolated setup or a nursing home setup. So what do you know, medical legal aspect also, and when do you activate the support system? So that is what we would like to know from you.
Right. So I think, as they say, there is safety in numbers. So when you know that things have started going downhill and they have taken a turn for the serious side of matters, I think it's important to not call, I would say summon. Summon your colleagues, summon other doctors who are in the same specialty or in other specialty who might help. So, for example, if there's somebody who is bleeding torrentially, I'll call someone who's even more senior to me. I'll call a general surgeon. I'll call a physician. I'll call an extra anesthetist to help. So the show of strength, as they say, is quite important. And this is very true in nursing home settings because you have to prepare a little bit in advance. If you're in a big hospital, especially in the daytime, you'll almost find every specialty around. It's not really much of a challenge. But when you're in a smaller place, mono specialty kind of thing, then you have to look at these things with a T minus 30 kind of a attitude. So start calling people early. You might have some false alarms, but that's okay. I mean, it happens once in a while. So that's one thing. Second thing is break the news in a way that is gradual. I mean, don't deliver the shock, especially when it comes to maternal conditions. Okay, perinatal mortality, you can't do anything. The baby is no more, it's no more. But maternal condition always goes slow, gives them some time to adjust to what you're saying. Let them calibrate, what is happening. And then by that time, you'll have some support system which you can create and get into place. These are the negative parts about, a nursing home. But I like to emphasize that there are certain positive aspects also. See, in a nursing home practice, typically these are patients whom I've been seeing for a long time. I mean, I've either seen them as patients themselves or I've seen them as relatives of other patients. And there's a lot of familiarity over there. They are familiar with the nursing home. They are familiar with the doctor. Some of them even know the staff who has been working at the nursing home. So there is a little better level of trust, if I may use those words, when we are in a nursing home situation. So there are positives and negatives in that kind of a setup.
Yes,
Inside.
that's important. The positive and negative aspect of nursing home practice, but very relevant practical point. Thank you, Dr. Tank.
There are different challenges in the corporate hospital, multi-specialty hospitals, and the nursing homes. Probably there is a better connect in a nursing home with the doctor and patient because it is one-to-one. That connect may not be as good as in nursing home with the in a specialty hospital. I don't mean to say that there is no connect, but yes, in a private nursing home, probably the connect is little more because the patients come by the doctor's name and become. There are pros and cons of both.
So,
Absolutely.
having been known the issues of pediatric practice and OBGY practice, that's where the bad news is really taken very hard. But Dr. Ravi, I would like to ask you that in intensive care scenario, again, bad news is such a common place. And how do you manage, when you have to see a number of patients in ICU with all different kind of issues? So, and different specialty being admitted under you, how do you manage?
So I know it's a challenging situation, but what is important is to be very calm and quiet when you are talking to the family. That is the first and foremost important thing. The second important thing is you have to talk to them in eye to eye. So you should feel, or they should feel confidence in you that what you are talking sense. The third thing is you have to give time for them to react. Right. The fourth thing is, you have to tell them about the positives. For example, if a patient develops an acute kidney injury and is going to require a dialysis after some time, whose kidneys was reasonably working well. So if I have to tell him that yes, now he is going to require a dialysis, before that, I will tell him 5 to 6 good point about the patient, that now that the blood pressure is better, the patient is more conscious, the infection is coming under control. And unfortunately, the infection has affected the kidney and the blood pressure has affected the kidney, and we might have to do a dialysis. So you get them into a good positive frame of mind initially. Then you tell them a negative thing or a thing that is unpleasant, that is unexpected to the family. And then you again tell them that you have treatment options for them. Like, if there is an acute kidney injury which requires dialysis, you tell them that, okay, dialysis is going to be temporary. Probably most of the time the kidney should recover. If it doesn't recover, even if the patient goes on a long-term dialysis facilities are excellent. The patient would survive well for 25, 30 good years, and everything has evolved well in this era. So this is very, very important, that you tell them the positives first. And the second thing is, if you are breaking a bad news or an unpleasant news like a death or something which has happened suddenly, it is very, very important to take them into the room. Don't tell it in the corridor in front of everyone. Take them in the room, make them comfortable, call not only one member from the family, 2-3 members from the family, so that they feel that they are emotionally supported and there is no emotional outburst. Or if there is an emotional outburst, it will be shared not only by the doctors, also by the relatives. And among these 3-4, you will find somebody who would accept that news in a better way. So there would be some counteracting persons, that one person might burst, the second person might, just might have a calming effect. So always have 2-3 people together, listen to them, and you should have an explanation. Never tell them, I don't know what is the reason why the patient is arrested or why the patient is bad. Even if you don't know, you have to tell them that, okay, these are the possibilities, these are the probabilities, we are trying to find it out, right? So you should look confident in saying what you are saying. So that is how it is very important to, be confident and calm and quiet. The other thing is, yes, sometimes it becomes very challenging emotionally that on one patient, you are very upset because the patient is deteriorated suddenly. And on the next patient, you have to tell them now he's doing very well and you are going to shift him. On the next, another patient, the very next patient, you are going to again tell, okay, his neurological outcome is very bad. He's probably going to be brain dead in some time. So yes, in the initial phases of my practice, the emotional challenges was too many. But as all the panelists has pointed out, with gray hair and experience and sensitization, you learn to cope up with those emotions and detach yourself. Though that doesn't mean you are not sensitive enough to the patient and the relatives for their loss or something like that. But at the same time, going back to the next patient and connecting with that patient with a positive attitude, that you learn over a period of time. And it is important to be honest with yourself as well as the relatives.
Excellent. So there are some questions from the audience. So Dr. Sangvi, you can take this question. What is the importance of the GP in unexpected bad news? Would it be wise to get him or her in the strength of number team? So both for Dr. Sangvi.
Of course, if you have a general practitioner, can you hear me?
Yes.
Hello?
Yes.
So it's GP is their first point of contact, and if the GP has referred the patient to you, all the more reason you should call him. And it'll be much easier for us because they trust the GP. They may not trust us. So this will help them to absorb the news because he will be able to explain to them better than we will do the technical part of it. But the emotional part, I think the GP would be much better off explaining it to them. That is, so I mean, so like when I involve an obstetrician, it is because the patients know the obstetrician and not me. So it's always good to have a GP along if you have.
So
true. I would second that. And many times in ICU we face such situations where different consultants have different opinions, about the patient management as well as the prognosis. That it would so happen that in the morning somebody would have told the patient that, or the relatives, that the patient is doing reasonably well, and maybe in next 3-4 days he's going to get better. And by the time of evening, you find that the patient is very sick and he's going to probably succumb to his illness. So then it becomes very challenging. So what is important here is that you need to respect your opinion of your colleague, which that is his perception, and your perception might be little different. This is again, as I made the point in the before, that beforehand I had made that point, that it is very important to look confident, that what your colleague has said and why he has said. You just need to manipulate a bit, why he had made his opinion and what has happened in last 4 to 6 hours that has made the patient bad. If you can explain those to the relatives, they would accept it.
But sometimes,
so generally, when I I always include my residents and preferably even the nursing staff when I'm counseling the relatives. So everyone knows, and all of us are on the same page, and no one gives a different opinion.
absolutely.
Right, absolutely.
I think this is very important.
Absolutely, it's a team. It is a teamwork. I mean, you can't go and just talk to them, because every time the resident comes in and out, evening duty, there's another resident, night duty, there's another resident. So I leave instructions that if at all the relatives get hold of you, this is what you're going to say.
Absolutely correct.
Consultants talking among themselves also makes things very easy. First of all, you are on the same page. You have consensus in your perception, and then convey like a team. That is much more important. So ever since in Jupiter Hospital also we started doing this multidisciplinary meeting. That is helping. Give one voice to the patient rather than different people saying different thing, and the relatives end up getting confused as to what really the prognosis is.
Sometimes it also so happens that one of the consultants, if there are 5 doctors treating a patient, one of the consultant would be somebody who would be in a very good book of the patient, and one of them may not be in very good book or may not be liked. So it is always better to involve that person who is in good book, and give his reference and say that we have spoken to him and he's also had the same opinion. This does help. Small tricks here and there, they do help in managing such situations.
It's the classic good cop, bad cop kind of switch,
No, when there is a multidisciplinary involvement, I generally try to have all the consultants together to talk to the parents. So we do a joint consultation rather than everyone talking individually. And if at all it happens that they have to talk individually, at least first we talk to each other so that we tell the same thing.
Absolutely correct.
It's not that the neurologist will come and say something else, and then the intensivist will come and say something else, and the nephrologist will come and say something else. So we have to be on the same page. That's very, very important.
Yeah. So
Any difference of opinion is going to get in trouble.
Absolutely correct. So communication amongst the consultant is very important and extremely necessary. And as Alpa said, we have such types of meeting which are called as MDMs. So any patient who has been sick for more than 5 days, or any patient who has developed a complication, all the consultants sit together and then talk to the family together. So that really helps.
So
Alpa, before going to the chat questions, I have one question for you. So you have been involved in a lot of spirituality and yoga and those stuffs. So do you see any role of spirituality in managing yourself in this difficult situation?
Yeah, absolutely. I think the first and the most important thing is spirituality helps you remain grounded and centered. When we have to deal with such situation, being composed, calm, and giving that positive vibe to patients is extremely important. And also, every time a bad news comes, if you are not spiritually grounded, you may end up taking this like a personal failure, and which used to happen in the earlier years of my practice. Every bad news used to be taken so badly by me, and sometimes if 2-3 bad cases would happen together, I would take it as a personal failure. So I think that's very important to keep yourself grounded. Second thing it helps is to connect with the patient and the relatives and being very honest, I think. So not giving any projection, but being very honest and giving them the truth at the same time without taking away the hope is something, that fine tuning or the balance I have found in spirituality. In fact, one of my patients who had adenocarcinoma and metastasis, he fought the battle for 4 years, and he was an absolute intellectual kind of person. But towards the end, he knew the prognosis, and he started coming to our meditation classes. And after few sessions, he did tell me that I've lost the fear of death now because I've experienced something which is beyond my body and mind. So these kind of experiences I've had. So at multiple levels, I think spirituality really helps to us personally as treating doctors, to patients and relatives. Okay, to come in terms with the truth.
So before going to the questions in the chat box, Alpa, if you can look into the chat box and we can take those questions. So something about UMANG, do subscribe and help us in sharing our UMANG's YouTube channel to spread the empowering way of UMANG amongst all medicos and have insight of various aspects and topics which are important in our day-to-day life, professionally as well as personally, from the stalwarts of medicine and many speakers that we have for so many years. We are available on YouTube channel. The name of the channel is Empowering Medicos UMANG. We are also available with the same name, that is Empowering Medicos UMANG, on Facebook. Please subscribe.
So just quickly, can we take some?
Dr. Dalal, I'm afraid I'll have to leave.
Okay.
I'm so sorry.
No, it's fine. I think
I am the last man.
Yeah. The last one to come.
It's an honor to be with you on the panel today, Dr. Sangvi. Many years ago,
thank you, Parikshit.
Thank you so much.
Yes.
Thank you, Ravi. Thank you, Alpa.
Thank you, Dr. Parikshit, for being
my pleasure.
Thank you so much.
So before we move on to the questions, I just want to add 2-3 points. One is about second opinion. Now, if you are in a difficult situation, it is always wise to take a second opinion. You encourage the relatives to ask for a second opinion, and at any point of time, take your ego aside and they ask for a second opinion, ask them, please call whomever you want to call, whomever you want to trust. And I remember when I started practice, Dr. S.M. Merchant, the grandfather of Indian pediatrics, I used to work with him. And anytime anyone would ask for a second opinion, I would go and ask, sir, will you please come? And sir comes, sees the child, and એને બધું બરાબર કર્યું છે. Those who understand Gujarati, he's done whatever best possible thing can be done. I have nothing to add. I've made a few changes. That's it. So once Dr. S.M. Merchant says that, then he was God. No one would doubt your treatment. So always encourage. When I'm in a difficult situation, even at this age and stage, I do ask for, if you want, they say second opinion, call whomever you want to. I've got everything. I'm an open book and I have nothing to hide. That is one. 2, hope. Yes, you can give hope, but don't give false hopes. Don't unnecessarily go on building their hopes to crash them later on. So if you want to give hope, see that they are really, when you are really hopeful. Lastly, documentation is very important. Even on my postnatal rounds, I write the notes myself. I don't ask the resident to write the notes. Maybe I have enough time to write the notes, but my daily rounds, morning, evening, in my NICU, wherever I go, I write the notes, and sometimes the nurses are surprised. My junior colleagues are surprised. Why is sir writing the notes as he does? Medico-legally, you are absolutely safe. That you have seen the child, you have advised this treatment, and that is why documentation is the most important thing. If anyone else comes, suppose God forbid there is some tragedy and you are hauled up to court and all, at least your documentation was there. Nothing was verbal orders. Like, this ministers say, "Kisko pakad lo," they ask for written orders nowadays. Everything is written in black and white. So that is very important if you don't want medical legal trouble. And then also verbal messages are not passed on from one resident to other. If you say you give 10 milligram, the residents say, no, in the book it is written 5 milligram. So I will give 5 milligram. But once I write 10 milligram, and I also tell the residents that if you think I am wrong, please call me. And please tell me, sir, this is wrong, you've written wrong. And I will correct myself. So we have to be keeping our egos aside. I know of many consultants who don't even talk about a second opinion, think that it's against their status to ask for a second opinion. But let them be happy. But I do. Even if they ask for a junior colleague to come and see the child, I say, please.
Absolutely. The openness about a second opinion is extremely important. And it's very good. Most of the time, it is going to help rather than harm.
So that's excellent points, some practical points. Thank you, Dr. Sangvi. So some of the questions, I think, is it always necessary? Dr. Kamath is asking, is it always necessary to give bad prognosis or should we give hope every time? So I think that was answered in Dr. Sangvi's last, what he shared, is that when the prognosis is really bad, then you can't beat around the bush. But if there are some options available, then yes, then you give first some hope, and then along with that, you tell the prognosis. And okay, GP's question is, and how are psychological issues addressed after breaking the serious news, especially in case of cancer diagnosis? So if you can have some support groups, or you have some system whereby you ask the patient to be referred, either asking some help from a spiritual master or having a support group. And I think providing support yourself really helps. Times in Jupiter, we used to have this meditation classes, and many relatives to join. And we have counselors available. So counselors can also counsel the relative. So definitely relatives need the emotional support, and that should be provided. If your institute has that, that's well and good. Anything else you have to say, Ravi? Or otherwise, I think most of the points are covered.
I think most of the points have been covered.
Yes.
There was one question, how to break a news of seropositivity for a patient who is tested positive, young patient. So Alpa, if you want to take that, or Sanjay sir?
Yeah, they would not be.
Not my cup of tea. I don't have any serious positive.
Yeah, so I think that point is already been discussed.
Then we're talking about seropositivity is about HIV, right?
Yeah.
Like I think like onco now, seropositivity also is not such a bad news because we have a lot of options available.
Yeah.
You just like whatever has been already shared, nothing different. I mean, you have to follow the same points and same principles and break the news, tell them the fact, but at the same time, a lot of options are available and not taking away the hopes, supporting the patient to continue the fight. That's what you have to say.
So sounding positivity in negativity is very important. That's the take home, I think.
I think we have had an excellent discussion. Thank you so much, Dr. Sangvi, Dr. Bowman, and Dr. Tang for being part of the discussion. Very valuable inputs, practical points, and what you've shared from your experience, and it's extremely useful, I think, especially for the younger colleagues, because we probably learned through our mistakes and how we had a professional maturity over the period of time, but our younger colleagues can definitely learn from today's discussion, and we've also learned many points today's discussion. And thank you all the participants for joining. Please do subscribe to our YouTube channel and attend our subsequent UMANG session. Thank you, all of you. Thank you.
Thank you, Dr. Sangvi, and those for whom those who have not been present here, they can listen to these discussions on our YouTube channel. It will be uploaded there. Thank you so much.
Thank you.
Bye.
Thank you, audiences. Thank you all. Thank you, Alpa.
Thank you, Ravi.
Thank you, Ravi and Dr. Alpa. Sandy sir गए क्या? He left it.
Yes.
Really nice, very well moderated.
Very nice. Very nice.
Yeah.
Thank you. Thank you.
I liked positivity and negativity. That was a good one. That's good.
Even Dr. Tank was good.
Yes.
Yeah. I mean,
I like the
his
concept of
resilience.
building the team,
Yeah.
building the support.
Absolutely.
It was different.
Yeah.
Excellent. Very
Yeah,
good.
very nice. Very well conducted.
Excellent work, Team UMANG. Me and Gauri are coming in once we finish our whatever we are doing team management leadership program. So sometimes we are just log in from the two devices and coming in. But whatever I heard, excellent work, Alpa madam and Ravi sir. Too good. And whatever the UMANG is doing, it is simply awesome. Thank you so much. And always spending time and with so much enthusiasm, you all conduct the programs. It is simply awesome. Thank you so much.
We have a captain.
The most enthusiastic person is Gauri. She manages everything, and it's all credit to her. Actually, we are just like supporting.
Absolutely.
That too with lot of
She's
pushing and all.
She drives the show. We are just like there behind the curtains.
Yes.
The one,
Yes.
कैप्टन मिल गया तो फिर टीम परफॉर्म करते हैं.
सही बात.
कैप्टन सबका कान पकड़ता है बराबर.
मस्त है. बेस्ट कैप्टन है.
ये बराबर बोला. Thank you so much. But ये सब लोग के बिना नहीं होगा. Yeah, that's true. Thank you so much.
Bye.
Okay. So, see you all. Have a good night. Bye. I will end the session.
Yes. Thank
Bye,
you.
Alpa. Bye, Gauri, Swati, Kanchan.
bye.
Bye.
Thank
Yes,
you.
sir. Bye,
Thank you,
sir.
Nilesh,
Bye,
and all the
everyone.
co-hosts who were
Thank
available
you,
there.
Nilesh. My daughter
Yeah,
was also
especially
there.
And all the co-hosts who were available.
Yeah, Ravi sir, wait 1 minute. So, especially I have worked in Jupiter under Ravi sir and Gauri ma'am. So, I have started my new clinic at a village at the Taluka place. So, here we have one multi hospital. I'm on call chest physician there. So, they call me for every chest patient, but they call me in critical medicine patient also just for counseling. Because I have learned that from Jupiter. So physicians here say, okay, Dr. Nilesh, please come. The relatives want to meet you. So this I have learned from Jupiter, especially from Ravi sir, Gauri ma'am, everyone. Because as a register, we were allowed to speak to the relatives. So that was the best thing. So that confidence I have gained from Jupiter. So thank you very much, everyone. So I'm proud to be a part of Jupiter always.
Thank you, Nilesh.
So thank you, everyone.
Thank you, Nilesh. Yeah. And best wishes for you. Thank you.
Best wishes.
Thank you, ma'am. Thank you, everyone. Yeah.
Bye, everybody. Good night.
Chalo, bye. Bye, Ravi.
Good
Bye,
night.
Tank.
Bye.
Bye, Alpa. Thanks. Excellent. Very well conducted. Ravi, Alpa.
Thank you. Thank you.
Congrats.
Bye.
Okay. Bye.
End करा था.